Morning. I'm Liz, like Mike mentioned, and I've been at UW now for 7 years, total of 9 years in practice taking care of patients with cancer. I primarily work within the gastrointestinal, breast, and brain cancer clinics. Not saying I haven't dabbled in other tumor types, but those are kind of my forte, kind of moving forward. Today, you get to have me twice in your lecture series. Today, we're going to focus on immune checkpoint inhibitors and gastrointestinal targeted agents. Of course, this is not an all-encompassing, I'm not going to teach you everything possible because that would be many days of lectures in regards to these topics, but at least give you some pearls, practice pearls, how to manage patients and so forth. So without further ado, let's get started. Let's see. Perfect. So let's review the FDA approval timeline and all the different agents that we have available. Now, listed here on the slide are the years that they were first FDA approved. So this does not include all the rapid indications that some may have gotten in the past or in the years after they got their approval. So the first guy on the market was ipilimumab, and that is our CTLA-4 inhibitor. It essentially revolutionized the treatment of patients with melanoma. This one came out when I was actually in residency, and it was really, really exciting. Fast forward to 2014, that's when pembrolizumab and then a couple months later, nivolumab got their first indications for melanoma. Fast forward, then we get a little more specific, and we're now into our PD-L1 inhibitors, atezolizumab, then avelumab, durvalumab. As you can see, we got many on the market. Cemiplimab, many of these are considered me-too drugs, especially when they target the same receptor, so PD-1 or PD-L1. Then we kind of had a little break for a couple of years, and then in 2021, dostarlimab came on the market, and then in 2022, last year, we had the combination of nivolumab and relatlimab, and then another CTLA-4 inhibitor got approved, tremelimumab got approved. Not had enough coffee, clearly. Now, how do these drugs work big picture? So on the slide, we have our T cell and our tumor cell. The first drug, let's go back to like our basics. So CTLA-4, that was when the first drug, ipilimumab, was approved. That is on the T cell. Relatlimab, which we'll talk about coming up here, how it works, that hits leg 3. PD-1 inhibitors, cemiplimab, nivolumab, pembrolizumab, and dostarlimab are also on the T cell. A little bit more specific to the tumor cell for the PD-L1 receptor is atezolizumab, avelumab, and durvalumab. Now, I mentioned the leg 3 inhibitor with relatlimab. This is the newest indication for melanoma. What we know happens is, and I love this graphic from the drug company, your T cells get tired over time. And so how nivolumab and relatlimab, they think work, is it the relatlimab essentially works to energize those tired T cells up. So I kind of think of it as like caffeine to help wake those up. And then therefore those T cells are now active and can help to attack your immune system. Again, this is kind of the more recent approvals compared to the CTLA-4 and PD-1, PD-L1s. Now, this website here is a really cool resource, especially if you're looking at maybe when something got approved or what data it was approved based on. So if you look here, I took some, I took some screenshots of what this website shows, and it shows by year and month and by indication when things were approved. And if you hover over the different color little bullets, you can see what trial that approval was based on, because of course we have so many different trials in this arena. So for example, if you were looking at, breast cancer back in 2021, when pembrolizumab got approved, you're going to see the Keynote trial that was listed for that. And it can help you to determine what trials were done when, and you can see a timeline of when things were actually approved based on that. So a really cool resource if you want to explore that for more information. So now let's talk about just some basics of dosing. So most drugs have a couple different ways that you can dose it, which can be somewhat confusing, especially for our newer providers on the block. So our CTLA-4 inhibitors, ipilimumab, you'll see 3 mg per kg every 3 weeks for 4 doses, or 1 mg per kg every 3 weeks for 4 doses. Those are the two most common modalities. I think we've discovered over time that more is not always better when it comes to ipilimumab. So a lot of times, especially when it's in combination with nivolumab, you're going to see that 1 mg per kg used. Now, you will notice, though, some of the more recent things are even lower doses less often. So 1 mg per kg every 6 weeks. And you'll see that as a continuous dosing for those patients. There's no cap on that. Now, Tremi is interesting because it's only a one-time dose given on day 1 of cycle 1 when it's in combination with durvalumab. That indication is only right now in the HCC setting. What's really interesting is Tremi has been around for many years, and it finally just got its approval with durvalumab for that HCC indication. PD-1 inhibitors, the two biggest ones you're going to see is going to be pembro and nivolumab. We actually do not have dostarlimab on formulary, so that's still non-formulary at UW. Reason being, our providers determined that it's really a Me Too drug and it's Me Too indications at this time. But pembro and nivo, what's really nice is they are flat doses, and they're given pembrolizumab every 3 or 6 weeks, nivolumab every 2, 3, or 4 weeks. So you can see that can be convenient for the patient when they don't have to come in as often, especially when they're maybe on single agent therapy. Your PD-L1 inhibitors, atezolizumab, durvalumab, avelumab, again, doses are listed here. Atezolizumab is flat dosing. Durvalumab is both waist-based and flat. Avelumab is flat dosing. Again, every 2 to 4 weeks, depending on the indication and setting. And then finally, LAG-3 relatlimab, which would only ever be given in combination with nivolumab, is a flat dosing every 4 weeks. So let's talk about monitoring. Built within the Beacon treatment plans, we have tried to build and standardize how we monitor patients on immune checkpoint inhibitors. I think we started, 2 years ago to try to standardize what labs are in the treatment plan so that it's very consistent across the board. If you're looking at what you're going to be seeing in the labs, of course, most of our plans are going to be built with a CBC and a CMP, but you are also going to see thyroid function, so that TSH and free T4, and the cortisol, at least every other cycle that is going to be built within the plans. Now, something I will occasionally get questions about is in regards to monitoring amylase and lipase. We do know that routine monitoring is not needed for those patients, and those are just if you notice that the patients have or are having some symptoms in regards to like a pancreatitis type situation. We were finding, and I was thankful NCCN change, but we were finding that people would occasionally get some elevated amylase and lipase, and it would send us down a rabbit hole when really it was just the patient's normal either disease state or just not even related to immunotherapy. So now let's talk about in terms of monitoring and side effects and what you're going to see with these different agents. I like to go back to the history of melanoma treatment and then looking at the approximate number of patients that had grade 3 toxicities. So old school IL-2, it still exists. I actually don't know if it's still in the melanoma guidelines. It might be, it might finally be pulled from it now, but IL-2, we actually do not do that at UW. I believe MCW still does. I learned IL-2 treatments, and these patients have to be admitted to the ICU, as you're essentially putting gas on an open flame if you think of the immune system in that regard. So really, it's a non-specific T cell growth factor and essentially allows the immune system to be really active. And because of that, that is why that toxicity profile is so high. So 85% of patients have grade 3 or more toxicities. Capillary leak syndrome, hypotension, fever, myalgias, diarrhea, liver toxicity. I remember when I was a resident, I did my residency at MCW. I saw one patient in the ICU and they couldn't even get through all their scheduled doses. So a very toxic therapy with personally, I don't think a lot of bang for the buck. We've gotten a lot better. Now, ipilimumab, being that CTLA-4, when it is used as single agent, about a quarter of patients are going to have a grade 3 toxicity or more. And that, the common itis is colitis, rashes, liver toxicity. Now, we definitely got better, I would say, with Nivo and Pembro targeting PD-1, where only 15% on average patients have grade 3 or more toxicities. Then we combined a CTLA-4 inhibitor and a PD-1 inhibitor, and unfortunately, those two in combination, you will see an increase in toxicity risk. There is, though, of course, a benefit with having a better response when both are used in combination. And then finally, the nivolumab and relatlimab combination, about 40% of patients in the clinical trial had a grade 3 or more toxicity. So something to consider. It is definitely less than Ipi and Nivo, but those are never compared head to head, so you cannot compare those in that regard. If you look, though, at the classic toxicities, they're very similar across the board: CTLA-4, PD-1, PD-L1, LAG-3, and we'll talk more about those toxicities coming up. I love this picture. It's an old school picture, but it really shows what potential side effects can happen from immune checkpoint inhibitors. I think a lot of patients, especially if they're on single agent therapy, will go into treatment. And I know we do a good job talking about the itises and risks with patients, but it's not technically chemotherapy. And so they don't always consider the toxicities. But really, any sort of organ system in our body can be affected, some more than others. But I like this graphic because it can show all the different side effects that we might see. So let's talk about those side effects. So looking at this was a very historic graph that came out in 2015 for CTLA-4 toxicities. And this is a very common peaks and timeline of what we will see. So as you see with CTLA-4 inhibitors, the first side effect to come up is the rash and itching. It usually, though, resolves by about week 10. Then you see the diarrhea and colitis risk happen, and then that peaks. Further into treatment beyond 6 weeks, that is when you can see the potential risk of hypophysitis and liver toxicity. So again, all of those labs are going to be built in for those, but just knowing that you might see different incidences and timelines, and if a patient comes in, it'll help you kind of maybe tease out what side effect it potentially is. Now let's focus on the PD-1 and PD-L1 toxicities. So you have less incidence, for example, of skin rash and pruritus compared to CTLA-4 inhibitors. The colitis risk still exists. It's a little bit before that. Endocrinopathies are listed here. That risk really stays consistent over time. Just because somebody doesn't have an endocrinopathy within the first, 8 to 10 months doesn't mean it can't happen after that. Then looking at, other toxicities we realize can happen from these therapies include the pneumonitis risk, and then further into therapy, the nephritis risk. Now, when you combine ipilimumab plus PD-1 inhibitors, as you can see, the toxicity grade is worse, and that makes sense based on the other graphic I just talked about. And the duration, same duration for some of these toxicities like the nephritis and endocrinopathies, for example. So now let's talk about how to manage, where the bulk of the discussion should be, these adverse reactions. So there is a multitude of different guidelines that exist. UW, we still have ours, but it is extremely outdated. The data behind how to manage these toxicities is ever evolving, and so it's going to not be updated. So I would not reference the UW guidelines right now because they are not updated. But there is ASCO and NCCN. They have really good guidelines for managing toxicities. And so, of course, consult those if you're noticing a patient is starting to have a toxicity. But in terms of the general principles for managing these, this chart here lists it by grade, so 1 through 4. Action, what you usually are going to do with the immunotherapy. So if it's a grade 1, you usually can continue. Management for those patients, of course, close monitoring. Grade 2, moderate. You're usually holding immunotherapy, and you can consider resuming when it's grade 1 or less. You might see some steroids used for those patients. But grade 3 and 4, really, you're definitely holding that immunotherapy. You might consider in a grade 3 if it resolves quickly re-challenging. It usually doesn't go well, but you can consider that. And then usually the management of those patients is high dose steroids, and those patients, for the most part, are admitted, although some toxicities you might be able to manage outpatient at first. Let's go through some patient cases. So this was an actual patient of mine, MJ, 66-year-old female, newly diagnosed metastatic melanoma, presents to clinic for initiation of Ipi and Nivo. Past medical history, past surgical history, nothing really of concern with her starting immunotherapy. If when you are starting patients on immunotherapy, just to put it out there in case you don't know, you always have to examine if they have an autoimmune condition or if they have a transplant. So things to think about when you're reviewing starting therapy for patients. Doesn't mean, I should say, for autoimmune conditions that you can't give immunotherapy, but you're going to want to make sure that you talk to that other physician in regards to how well controlled that autoimmune condition is. ECOG performance said she was a Spitfire. Medications are listed there, nothing of concern that would interact. So she presents prior to cycle 3 of Ipi and Nivo. During a phone call with her, she had a mild rash on her upper chest. We did some topical 2.5 cortisone cream. She had used occasional diphenhydramine for itching. Unfortunately, though, the rash increased in size and it remained really, really itchy. So she's a few scattered areas of rash in her upper chest, abdomen, arms, and upper thighs. Estimation of rash involved 15 to 20% of her BSA. So skin toxicities from immune checkpoint inhibitors is very common, and it's the most prevalent. They're all, looking across the board, all are implicated. Some are more severe than others. So for example, when you combine CTLA-4 and PD-1, those are usually worse. It's a third of a patient regardless of tumor type across the board. So it's really important to educate about the rash risk. The most popular is, or the most common, I should say, is the maculopapular rash. So it's red and blotchy. And it's really important for patients to report in so that we can quickly manage at a lower grade. It is really important to calculate that BSA that's involved of the rash. That way you will appropriately grade and do the best recommendation for the patient. The rule of 9s here listed and how to calculate and then quantify that to help you in terms of grading it. So now looking how to grade, really focusing on this right side under the description. Grade 1 is less than 10%. Grade 2 is 10 to 30%. Grade 3 is greater than 30. And then grade 4 is any percentage, any papulosa and pustule tenderness, very severe. Again, those patients mostly would be admitted with that. But looking back at her case, MJ, she had 15 to 20% of her BSA covered. What grade would she be? So in the chat room, which, oh boy, Mike, how do I find the chat?
Yeah, the very top bar, you should be able to see it. And I can watch it too for you.
I don't even have a top bar. Somebody commented grade 2. Correct. Yes. She's 15 to 20%. That puts her at grade 2. So how do we manage dermatologic toxicities? So with grade 1, you can just do topical emollients, maybe a moderate potency topical corticosteroid. Again, those avoiding skin irritants, sun exposure, oral antihistamines. You can continue ICPI therapy. Grade 2, which was where MJ was, topical emollients, oral antihistamines, now a medium to high potency topical corticosteroids. If patients are unresponsive to topicals, the guidelines now list out initiating low dose prednisone, so 0.5 mg per kg per day. And then grade 3 and 4, those would be high potency topical corticosteroids in addition to the topical emollients and oral steroids, or oral antihistamines, excuse me. Prednisone then dosed at 0.5 to 1 mg per kg per day. In regards to the steroid dosing in general, if you can always start at the highest level, so like 1 mg per kg, and you can do a quicker taper down to 0.5 if the patient actually has a really good response. It's something that you'll start to understand how to dose steroids with ICPI toxicities over time. But I always say start high and then you can quickly taper. Of course, depending on the toxicity, some toxicities need really slow tapers, but you usually can get it down faster. In grade 3, you're going to hold, grade 3 and 4, you're going to hold, you're going to consult dermatology if you should be able to resume it. This is my plug for our amazing oncodermatology here. They're really good resources for that sort of thing. Now, potency of common topical corticosteroids. I included this slide just as a reference. It's also listed in the UW ICPI guideline. Not all steroids are created equal. And so as you can see from this chart, for example, triamcinolone dose between 0.025 to 0.1, that's a medium. Potency steroid versus high is your fluocinolone, betamethasone, for example. What's nice about this chart too is it contains the dosage vehicle. So, you have ointments, creams, lotions. Ointments can be very difficult and greasy for patients, so keep that in mind. A lot of patients, I don't have success with large surface areas of ointment application because then they're just all greased up, versus I have a little more success with the lotions and creams. So ICPI, going back to our case, she's grade 2. We held Ipi-Nivo. We started other supportive care meds. Patient would like to avoid oral steroids. She said she would get jacked up. And then we followed up in a week. So based on her grade of toxicity, which therapy would you recommend? So listed here is a bunch of different potency topical steroids. Based on grade 2, what would you recommend? I'll give you a second to read through those. I see lots of answers for D, which is the correct answer, a moderate potency steroid. So triamcinolone 0.1% cream applied twice daily, and then hydroxyzine by mouth as needed for itching. Excellent, guys. Okay, so she comes back to clinic 1 week later. Her rash continued to worsen, unfortunately. It's now disseminated, covering approximately 50% of her BSA, and she now has grade 3 ICPI. So now that she has grade 3, what would the best treatment option be? So I'm seeing some D's. I would make the argument for C. Reason being, I think grade 3, 50% of a BSA. She trialed topicals outpatient. We actually did admit her just because she didn't like how she knew she wasn't going to tolerate oral prednisone at home right away. And so we did give IV methylprednisolone. You could make the argument to try and not admit her, of course, because of bed crunch and trying oral prednisone. But if there's any concern or this, just based on your gut feeling of how bad the rash was and how fast it spread over the course of a week, that was why we decided to admit her. But yeah, you could argue C or D. So she presents back to clinic 1 week after discharging. She was tolerating her prednisone. She had a supportive care meds on board in regards to being on steroids. Listed here was the plan for a steroid taper. Now you will discover that sometimes your steroid plans, you have to adjust over time based on how the adverse effect is actually being managed and controlled. Some you're going to be able to taper quickly over anywhere from 2 to 4 weeks, versus some you might see yourself doing a longer taper. We actually very interestingly had a taper this past, oh gosh, it was August into September, where the patient had both an acute hepatitis and nephritis, and we were tapering over the course of about 10 weeks because it started in July. His numbers just weren't budging, and so he had to stay on a high dose with a gradual taper of 5 milligrams over the course of a week. Each week he would go down by 5 milligrams. So just know that you might need to adjust your planned taper over time because of how the patient responds and how the labs or the rashes look, for example. Okay, ICPI case number 2. BG is a 50-year-old male with no significant past medical history, with the exception of PD-L1 positive gastric cancer, being treated with pembrolizumab. Presents to the ED after his fourth treatment, complaining of fatigue, nausea, and abdominal pain. He has some yellowing of sclera. Looking here at his lab values that they received, as you can see, his ALT and AST are elevated. Billy remains normal, within normal range. So hepatitis is, sorry, I got an annotation request. Hepatitis management really is based on what the levels are, ALT, AST, above the upper limit of normal. Listed here is what you should do based on that elevation. So grade 1 is less than 3 times the upper limit of normal. You can consider holding and just assess the LFTs more frequently. Grade 2, 3 to 5 times upper limit of normal. You're going to hold the immunotherapy and then monitor LFTs every 3 to 5 days. You can always do it more often if you are concerned. So you can always maybe do it at 2 to 3 days from those labs, and then decrease that or increase that frequency, push it out with how often you want to monitor. You can consider prednisone per the guidelines at this stage. Severe is 5 to 20 times upper limit of normal, so a really big range there. You're going to hold, you're going to initiate prednisone for those patients. Listed here is things which you should do if it's refractory. A big thing with hepatitis is infliximab should not be used. Grade 4 means that they're above 20 times the upper limit of normal. At that point, you should permanently discontinue that immunotherapy, initiate prednisone. Consider hepatology consultation, especially if they're admitted. Not all patients need to be admitted if they're stable, but you just have to have a really good monitoring plan for them. If there is no improvement in the steroids, you can consider mycophenolate for those patients. Okay. According to the guidelines that we just discussed, which of the following best describes the initial recommendation of a grade 3 ICPI-induced hepatotoxicity? Yes, option B is the correct answer. You're going to hold immunotherapy and you can consider steroids. So yes, grade 3, this patient had grade 3 induced hepatotoxicity. Initiate prednisone 1 to 2 mg per kg per day. Follow up LFTs every 1 to 5 days until normalized. On average, I would say we do it every 2 to 3 days, and then taper the prednisone as tolerated over 4 to 6 weeks. ICPI case number 3. So LH, 32-year-old female, diagnosed with stage 3B TNBC in October 2021. She received carbotaxyl AC Pembro, then underwent mastectomy in May of 2022. She received cycle 12 of Pembro 400 on 8/23. So within our plan for breast cancer, on cycle 8, we actually convert them from a Q3 week to a Q6 week pembrolizumab. There's no differences in toxicities, but just know that sometimes, depending on the clinical scenario, you're going to see the ICPI doses change, just so patients aren't having to come and see us as often. So beginning in September of 21, that is a typo, 8/23, that was 8/21. I'm thinking of just this year. Anyways, it was in 21. There's multiple calls where she just has this vague nausea, abdominal pain, no diarrhea. We trialed different PPIs, H2 blockers, thinking maybe it was just all post chemo. Her CT scans were all negative, which was a really good thing. We got a GI consult because all of the above was not working. They got a colonoscopy, which was negative. Her stool testing was all negative. H. pylori was negative. They followed up with her, started sucralfate, PPI, and ondansetron as needed for nausea. Well, actually, we scheduled the ondansetron. Unfortunately, it really didn't work. She presented to the ED with nausea, vomiting, and inability to eat. She was discharged with an urgent EGD consult placed. So the EGD was done. They were consistent with autoimmune gastritis. Patient continued with nausea, vomiting, inability to tolerate orals, and it had an 11 kilogram weight loss. So she's currently 55 kilos. Based on the information, which of the below answers would be the best recommendation for the patient? Now, very interestingly, you noticed I did not include any guidelines for this. So NCCN does not contain anything about gastritis. ASCO, they mention gastritis in a section, but there's not actually a section talking about how to grade and how to treat it. So that is why I added this case this year. So what do you think? Yeah, so I'm seeing C's, C's. I would say C and D would be your best options. And blast them with a PPI. Going back to her case, just what happened. So 12-6, it actually started IV methylprednisolone 2 mg per kg daily. We started with a higher dose, just given the inability to eat, the persistent nausea, the failing of everything else. They started high, but then were quickly able to taper, as you can see, to so a couple days later, after 2 mg per kg, they bumped down to 1 mg per kg. She had rapid improvement in symptoms. She was discharged on prednisone, 60 milligrams daily, and all the PPX meds that she needed. Now, she required a very slow taper. So we attempted a taper by 10 milligrams weekly. Unfortunately, we had to adjust that to 5 milligrams weekly because her symptoms would actually worsen. When we got her off of steroids many moons later, she actually had a recurrence in her symptoms. Of course, we permanently discontinued pembrolizumab. Her last dose was back in, was that September? I'm forgetting our timeline here. No, it was actually August. This is really, well, patient case, she's doing fantastic well. She has no evidence of disease, which is amazing. And her symptoms she did have to do a 1 milligram per week taper. Final steroids were in April of this past year. But this is really the discussion points. A couple discussion points here is gastritis it's a rare side effect. It's really not included in guidelines. They're non-specific symptoms. Thankfully, she had a pretty speedy workup, and she really advocated for herself of like, I did wonderful during chemotherapy. I thought just being on pembrolizumab, I wouldn't have these symptoms anymore. There are case reports talking about gastritis, but there's really that lack of guidance. And unfortunately, I've had 3 different gastritis cases in my career, and all have taken a very long or needed a very long and slow taper. So final thoughts on ICPI therapies. A couple of things we did not talk about. So a lot of ICPI therapies are actually combined with different cancer therapies, either cytotoxic chemotherapies or targeted therapies. Now there's this debate about, using dexamethasone for anti-nausea in, especially your chemotherapy and ICPI combo plans. Some studies included dexamethasone just as part of their routine for nausea management because we know it works really well at preventing nausea. So breast, for example, it was included in those, but it's excluded from others. So, for example, in lung. So really, I think at this point in time, the effect is not known. It's short courses of steroids is what we're usually doing. Those plans are usually not plans that I would recommend doing more of a steroid taper for nausea. Use something else, for example. And of course, a lot of the studies excluded patients on steroids. The dose was usually 20 milligrams or above, so those patients were excluded anyway. So food for thought on that. In terms of interactions with immunotherapy, we really don't know. There's so much that we don't understand. And so you'll see in the literature information in regards to PPIs, potentially reducing it, NSAIDs, reducing the efficacy. Supplements and herbals, one of my favorite topics. There's a lot we don't know what these potential herbals or supplements are doing. So for example, some of the mushrooms that are out there, the turkey tails, those actually they think interact in that immune environment. And so I always say avoid those. I know some of my physicians, they kind of do this blanket statement of anything is okay. And I don't agree with that. But when you do have ICPI therapies in combination with other therapies, sometimes it is challenging to tease out what side effect is from what drug. That will come with time and practice. And then finally, you'll notice as you're rotating through different areas that some disease states, some dots have particular preferences for what ICPI therapies they have, which is why some ICPI therapies may not be built in Beacon. So if you're looking for something and you're like, wait a minute, just ask somebody, and it's most likely they had to have a preference, especially if there's the same type of drug approved for the same indication. So ICPI therapies, they're key treatment options for numerous malignancies. We have rapid approvals. NCCN has a really good patient education handout. Dr. Kratz actually showed me this, so you can always hand that to patients. It's lovely. We as pharmacists actually give wallet cards to our patients, so they will get those. And then, of course, utilize your neighborhood-friendly pharmacist. With that, and looking at my time, I'm going to segue into gastrointestinal targeted agents. Here we go. The first two I want to talk about are panitumumab and cetuximab. We are a predominantly PANI institution. Both drugs have very similar efficacy. Way back when, even before I started at UW, they did a cost analysis and PANI won out. We do have some clinical trials with cetuximab. We'll occasionally still use it in some indications or if it's like a PSR build, but just know you're going to see a lot of PANI. The dosing is listed here. Both are every 2 weeks, which usually aligns if they're combined with chemotherapy. These drugs do have infusion-related reactions associated with them. You'll see, for example, in the cetuximab builds, there's going to be pre-medications. We'll talk about side effects, the EGFR isms coming up. This one is a culprit of wasting magnesium. So this can result in really low magnesium levels. So make sure you're monitoring and supplementing as needed. How it works, it binds to the cell surface epidermal growth factor receptor, preventing EGF and TGF alpha binding and signal transduction. Therefore, the signal can't get in the cancer cell and they can't grow. Of course, cetuximab is approved in different indications like head and neck. So I'm only really focusing on the colorectal cancer arena. For colorectal cancer patients, though, you must be CRAS wild type. So just know that. Patient education, we're going to talk about this, but especially the signs and symptoms of low magnesium that can happen. So this EGFR rash to highlight, there was the STEP trial, which was a phase 2 open label randomized trial doing a preemptive skin regimen in patients to try to prevent that rash. A preemptive treatment, what we do is skin moisturizer, preferably, especially the face and chest one with an SPF in it, because we know UV rays can make the rash happen and make it worse. Topical hydrocortisone, either 1 to 2.5% applied at bedtime to that face and chest, and then oral doxycycline. So the trial did it for weeks 1 through 6. We kind of do this continuously within our patients. So incidence of grade 2 or more acneiform rash was 29% in the preemptive group versus 62% in the reactive group. So the reactive group, they added on this stuff as the rash happened. So it's really important, especially in the GI population, that you are doing this preemptive approach. So what does it look like? It looks like acne, but it's not actually traditional acne, and we should not be treated as that. So a lot of times patients are really going to want to pop the pustules, tell them not to. Do not let it dry out. Letting it dry out actually worsens the rash and makes it actually spread more than it would if you actually kept it well moisturized. Most common places: face, scalp, back, chest. There is, for example, in the scalp, if you have a patient that starts to develop it, you can do a topical clobetasol shampoo. That does work for some folks. So just know that that is an option because you can't use a topical hydrocortisone cream in their hair, for example. Early onset, so it usually happens, I would say, within the first 2 to 4 weeks on therapy, and many patients get the rash. What's really challenging with it is it waxes and wanes. So you might have a flare up and it gets better. Things go well for a while, and then you might get another flare up. Listed here on the slide are the other side effects that Pani and Satex can cause. So as you can see in the nails here, it causes this, like, I'm forgetting the real fancy word right now, of course, but it can cause these infections around the nail bed, and they can become very, very painful and sore. So this is a really good example of Pani nails. Then it can cause eyelashes and eyebrows to grow tremendously, and sometimes they're curly. So patients have to be educated. They probably shouldn't trim them themselves, but having a caregiver trim their eyelashes and eyebrows is a thing. And here, yeah, here's another photo of just like the nail bed and what can happen with the Pani nails. And then, of course, the acneiform rash on the face. Thankfully, in regards to those other side effects that that other, traditional cytotoxic chemos can cause, Pani really doesn't. But if you look at the effects that this can have on the hair, skin, and nails, it is something for you to consider, that it's not always necessarily a better tolerated per se therapy. We do have a lovely health facts for you for patients, so you can always print this out for them. It contains a lot of good tips and tricks for all of those skin, hair, and nail changes that can happen. Okay. Let's move to capecitabine. This is the oral prodrug of 5-FU. You'll notice that it's used in combination with potentially oxaliplatin or used in combination with radiation. Big interactions with capecitabine include warfarin, so I always am examining the med list to make sure that the patient's not on warfarin. Patients need to be educated about the hand-foot syndrome risk, diarrhea, mucositis. It can cause myelosuppression, but not, I would say, not to the extent that you see other chemotherapies drop the counts. But let's talk about hand-foot syndrome. So it's this dryness, cracking, and peeling on the palms of the hands and soles of the feet. Capecitabine, 5-FU, other agents such as like Doxil can cause this. Symptom onset is quite variable, but usually the longer that somebody's on it, the more likely this reaction is to happen. I talked about the symptoms, the redness and swelling. In really severe cases, it can become painful, and it can cause soreness and redness, and almost they look inflamed. Now, capecitabine is an oldie, but still a goodie drug, and kind of exciting because not a lot of supportive care gets studied in this realm. But at ASCO this past year, there was 2, I would say, major updates in terms of toxicities management for these patients on capecitabine. The first one is using topical diclofenac. It was the DTORCH trial. Patients were randomized, breast cancer and GI cancer patients. They received topical diclofenac, which is over the counter. They applied it twice a day to the palms of their hands and soles of their feet versus a placebo group. What's really awesome is 20 patients developed any grade hand-foot syndrome, 6 in the diclofenac group versus 14 in placebo. It was a small study, but it was the grade 2 and 3 was 3 in the diclofenac group versus 11 in placebo. So please use this, especially if you're using higher doses of capecitabine, and or if you're really concerned about, the patient's hands are already cracking and peeling. I would probably advise to use topical diclofenac. It's not built in our treatment plans yet, but it probably will start to in the next couple of years. Now, this 7-on, 7-off schedule has been studied in a metastatic breast cancer patient population. I know we're talking about GI drugs here, but you can also use this in GI. So they randomized 153 patients to either a set dosing of 1,500 milligrams by mouth twice daily, 7 on, 7 off, versus FDA approved dosing. So that would be 1,000 to 1,250 milligrams per meter squared twice a day, 14 days on, 7 days off. Now they actually looked at the overall survival. There was no difference in what they called the fixed dose. So FD is the fixed dose, 21.2 months versus 19.6 months in the standard dosing. It was actually higher in the fixed dosing. And then toxicity was actually better in the fixed dosing, and this was statistically significant. So in terms of patients DCing it, 21 patients in the standard dosing versus 6 in the fixed dosing. And of course, grade 2 and 4 toxicity, as you can imagine, occurred more frequently in the standard dosing versus fixed dosing. So, how I'm extrapolating this is if you see a patient that, maybe older, maybe a little bit worse performance status, you could consider doing the 7 on, 7 off, and they'll probably tolerate it better. Or if you have a patient who is on like standard dosing, not doing well, I would consider moving them to more of a fixed dosing like this. We have a health facts for you available for hand-foot syndrome so that you can always give this to patient, especially just it contains good tips and tricks what to do if that hand-foot syndrome develops. VEGF inhibitors. So we use a lot of bevacizumab within the GI population. Of course, it has many, many, many different indications. How VEGF inhibitors work, it binds to vascular endothelial growth factor ligand, preventing it from getting to the receptor, therefore decreasing angiogenesis. Tumor can't grow its blood supply. The thought is it stabilizes tumor growth and or potentially shrinks it. Toxicities, anytime you affect angiogenesis, you can see hypertension, bleeding episodes, poor wound healing, proteinuria. So everything, urine results are all built within your treatment plans. Of course, you're going to be monitoring patients' blood pressure, signs and symptoms of clots and bleeding, and you need to hold around surgical procedures. Lonsurf, trifluridine tipiracil. It's used in a late line setting for colorectal cancer. I like to talk about it. It's more of a traditional chemotherapy. So trifluridine is a thymidine-based nucleoside analog. It's incorporated into DNA, interferes with DNA synthesis. Tipiracil is not actually a chemo agent, but it's a phosphorylase inhibitor, and it actually increases the exposure of trifluridine by inhibiting its metabolism. Dosing is listed here, so it's 35 milligrams per meter squared per dose twice a day on days 1 through 5 and 8 through 12. We, though, at UW know, and it's something we do, especially in Dr. Deming's clinic, where we alter that and do days 1 through 5 and 15 through 19. Patients tolerate it better, have less signs of myelosuppression. You will notice Lonsurf is FDA approved now in combination for late line colorectal cancer, combined with bevacizumab. Regorafenib, multiple indications. This would be late line colorectal cancer. I probably only get a handful of patients that get regorafenib each year now. Dosing is 160 milligrams by mouth daily on days 1 through 21 of a 28-day cycle. I would, and it's built within our treatment plan. I don't want to say the word firmly, but I would strongly consider that you would ramp a patient on regorafenib. So start at 80 milligrams, then go to 120 milligrams, then go to up to 160 based on the tolerability for the patient. This one can cause hand-foot skin reaction, diarrhea, hypertension, rash. It's a multi-kinase inhibitor, so it's hitting a lot of different kinases, meaning that the side effect profile can be robust. I personally don't like regorafenib a lot just because of that high amount of side effects that can happen, diarrhea, hypertension, and that hand-foot skin reaction. Sorafenib used in our HCC and GIST patients, 400 twice a day continuously. You can also consider tapering this one also, or a ramp up. So do 200 twice a day and ramp up to 400. Toxicities are very similar to regorafenib. I would say sorafenib is actually a little bit better tolerated, although it's still a multi-kinase inhibitor. Big things with these and just globally across this class: hypertension, diarrhea, hand-foot skin reaction, electrolytes, and fatigue. Okay. I added this slide this year and it makes me happy. But let's chat about skin toxicity. It's a question I get a lot. So the first slide with the discolored nails What sort of agent or agents or classes of drugs, because I know you've gotten some of this, would that be from? Think of your more traditional cytotoxic agents. Somebody can always guess. Yeah, Devin, thank you. Yeah, so taxanes cause this nail discoloration. It's usually not painful. Sometimes it can become very more severe, and we're sending people to Oncoderm, but the discoloration of it is definitely taxane based. Excellent. Now, the middle picture is more of a dry, scaly, kind of peeling toxicity. What class of drugs would cause that? Or what drug did I just talk about recently? Yes, Cape and 5-FU. That's a Cape foot. Of course, there's other drugs that can cause the hand-foot syndrome, but yep. Now, the last foot, little did you know you guys are going to be seeing feet so early in the day. This is more of a callus blister-like appearance. This is considered your hand-foot skin reaction, which can be from those multi-kinase inhibitors, which is different from hand-foot syndrome. And I think I just gave away my answer. So yeah, your multi-kinase inhibitors, sorafenib and regorafenib, people's feet are going to look like that versus the Cape foot. Thanks for entertaining me today, guys, and answering. So that hand-foot skin reaction is you can see peeling, but it's most often calluses and blisters. Here listed on the slide is the grading and how to treat it. It is different than hand-foot syndrome. With this, if they're calluses, you can use a pumice stone to, kind of take down some of those calluses, especially on the pressure points. But if you're seeing patients with those blisters that are really painful, you're usually doing topical moisturizers, urea creams. You can use some topical lidocaine or oral analgesics. If pain, and this is in really severe cases, if drug is not stopped an appropriate timeline, you could see GABA agonists, sometimes narcotics in cases where it's really, really severe. But hopefully you would be stopping and a patient would be reporting in if it's developing. Ooh, new fun guys on the block, pemigatinib and futibatinib. Futibatinib is probably my drug of 2023. I just love that drug name. Listed here on the slide is how it works and what other things it hits that causes some of its side effects. This is a really good, I forgot to include the reference. I can add it. There's a really good reference of how to manage FGFR inhibitors and their side effect profile because it's very, very unique. So pemigatinib was the first guy on the market. It is a cycle base, so days 1 through 14 every 21 days, approved for FGFR2 genetic alteration cholangiocarcinoma. Actually, both drugs are. Futibatinib was just approved this year, 20 milligrams once a day continuously. We have used both for patients. What's kind of challenging in the guidelines is in getting insurance approval is futibatinib has not been studied after pemigatinib, but we've used it in that setting. So sometimes you might have to argue with the insurance. But side effect profile, this can cause hyperphosphatemia. So you need to be monitoring the phosphorus levels for patients. It can cause nail and taste changes, but it also, both drugs can cause eye toxicities. So patients need baseline ophtho exams and then getting those every 2 months for 6 months and then every 3 months thereafter that they are on the drug. Listed here on the slide is what to do with those if you get elevated phosphate levels. So when to initiate a phosphate binder is anytime that you have a phosphate level greater than 7. So very important to note and when to start those for patients. Ivosidenib, I wanted to touch on this one this year. It's, of course, approved in AML, but it's also approved in IDH1 mutated cholangiocarcinoma. It's a continuously dosed drug, so 500 milligrams once a day. This is an oral small molecule inhibitor of IDH1 enzyme. Biggest things with this one in pearls, just because I'm running out of time, make sure that you're monitoring ECGs prior to initiation and at least weekly for the first 3 weeks, and then monthly for the duration of therapy. I didn't realize the impact that these had until I actually had a patient with QTCs over 500 on this that required dose reductions and holding therapy at some point. But in general, besides that, yes, I've seen some nausea and diarrhea, but this one is actually pretty well tolerated, I would say, compared to others. Okay, I made it with 4 minutes to spare for questions. Just to conclude, of course, ICPI indications, they're ever evolving and changing. There's new things, I swear, every week. But our toxicities are evolving and changing too, and management of those. Consult your experts. And really, what's really exciting, the phase that we're in, ICPI and just different immune-based therapies, it's just growing and expanding. So giddy up, folks. It's a really exciting time. And then GI targeted therapies are growing too, just with the approval of futibatinib this year. Things are rapidly changing and managing. Knowing your difference in skin toxicity is important for patients, especially on these GI agents, and how to manage. And then, of course, I plug for my colleagues and myself. I work with some really smart pharmacists. And so if you're ever in a different area, find your expert and consult them when needed. And with that,